My name is Caitlin. I'm a licensed marriage and family therapist. I've been a clinician for a little over 4 years now and have experience working with both adolescents and adults with co-occurring disorders in the RTC setting. I began my career here at Evolve as a primary therapist, and now I'm currently the program director for our DBT comprehensive houses in Los Angeles. I'll pass it over to Rachel now.
Thank you. Hi, everybody. I'm Rachel Moskowitz, another clinical program director with Evolve. I actually started my career, my first job out of college was as a residential counselor in RTC, and now 20 plus years later, I'm a clinical program director here at Evolve. But in between, I've worked with adolescents at all different levels of care. So I've done private practice and intensive outpatient work as well as partial hospitalization. So, working with high-risk adolescents is definitely close to my heart. And we will go ahead and get started with a little bit of an introduction and some content. So, mental health clinicians working at every level of treatment must be able to quickly and effectively assess the risk of client suicide and intervene appropriately. The goal is for this webinar to provide a review of the prevalence and risk factors associated with suicidal ideation, suicide attempts, and suicide completion in adolescents. It will also provide an overview of helpful assessment tools, strategies, as well as interventions. And we are going to also make sure to be using case examples throughout the webinar in order to illustrate and clarify the information provided. So this is our overall agenda. Please don't hold us to this exact time frames, but for the most part, we're going to be starting off talking about some important statistics and definitions so that we're all on the same page. Then we're going to be going into risk factors, triggers, protective factors, signs, symptoms, as well as assessment. And then at the end, we'll be going into responses, interventions. We'll also open it up at the very end for the questions that you all have entered into the Q&A throughout the presentation. And then the plan is to go through a case vignette and sort of, pose some questions to you all in the audience and open up the chat at that point for you to contribute your own thoughts. So with that being said, we will go ahead and get started. So some important statistics, I'll sort of give a little bit of background. Every 2 years, the CDC conducts a youth risk behavior survey. So these statistics come from the survey that was published in 2024. The survey is designed to help the CDC analyze the prevalence of mental health and suicide risk indicators and their associations with individual, family, schools, community level protective factors. So it'll be interesting to see, the next publication will come out in 2026. So it'll be interesting to see how these have changed and shifted in the next year or so. But suicide is currently the second leading cause of death for children ages 10 to 14, and the third leading cause of death for those aged 15 to 24. In both age groups, accidental deaths such as poisonings, car accidents, accidental drownings, those remain number one. Having said that, between 2000 and 2021, rates of suicide for 10 to 24-year-olds increased by slightly more than 52%. About 20% of adolescents, or 1 in 5, seriously consider attempting suicide, and just under 10%, or 1 in 10, do in fact attempt suicide. Caitlin is going to get a little bit further into risk and protective factors, but I did just want to mention from a cultural standpoint that interestingly, while the consideration of suicide and actual suicide attempts do vary by race and ethnicity, there really haven't been consistent patterns that have emerged through current research, except for patterns linking certain risk indicators to specific racial or ethnic groups. So for instance, Hispanic teens show a greater prevalence of persistent feelings of sadness and hopelessness and attempted suicide, while Caucasian teens have a greater prevalence of poor overall mental health. African American teens, as compared to both other groups, showed a much lower prevalence of poor mental health, but had a significantly higher prevalence of attempted suicide. And then Asian teens had the lowest prevalence of seriously considering suicide as compared with Black, Hispanic, multiracial, and Caucasian teens. In terms of gender identity, female adolescents experience higher rates of depression, considering and attempting suicide, while males have higher rates of suicide completion. And then LGBTQIA adolescents have higher rates of attempts and completed suicides across the board as compared with heterosexual adolescents. So moving on a little bit from statistics, we're just going to go through some basic definitions that my guess is that most of you are familiar with, but I just want to make sure as we talk that we're sort of all on the same page. So the first definition is passive suicidal ideation. Passive suicidal ideation refers to having thoughts of death or a desire not to be alive, but without a specific plan or intent to act on these thoughts. So in terms of working with clients, this can sound like a lot of different things. Some common ones are things like the world would be better off without me. There's no reason for me to be alive. There's nothing in life to look forward to. Life is pointless. Things are always going to be like this, and life is never going to get any better. So those are all examples of passive ideation. Active ideation means that an individual is not only thinking about suicide, but they also have the intent to die by suicide, and they may be actively planning how to do it. So active ideation, it's important to point out, and we'll go into this more later, requires immediate attention and intervention. So some examples of active ideation include: the only reason I haven't done it yet is because I'm waiting until my parents aren't watching me so closely, or it would be easy for me to kill myself. I know exactly how I would do it. I'm going to kill myself tonight, or the next time my depression gets this bad, I'm going to do it. So suicide attempt, an individual has taken action with the intent to end their life, whether or not the actions are actually lethal. It's important to know that previous attempts, even just one, is a critical indicator that future attempts are likely. We can't assume that just because the first attempt was non-lethal, that the second attempt will also be non-lethal. And I want to just sort of offer an example of a non-lethal attempt. I worked with a client who mixed beer with dish soap under the impression that this would end her life. It was not lethal, but because her intent was to end her life, that was still a suicide attempt. And then suicide completion, a person has ended their life successfully through suicide. I don't have a slide on this, but I did just want to mention, because Caitlin and I are going to be sort of dropping terms like outpatient care, IOP, PHP, RTC, and I just want to make sure, since there's sort of a diverse representation of clinicians in the audience, that we're all aware of what those are as well. So when we refer to outpatient care, typically what we're talking about is anybody providing care in a private practice or group practice setting. IOP stands for intensive outpatient programs, and these teens usually attend after school. They can be 3 to 4 days a week for 3 or 4 hours at a time. Partial hospitalization is a step below residential treatment and usually looks like 8 hours, 8-hour chunks of time, 4 days a week. And then RTC, this is for teens who require 24-hour-a-day supervision. This is what Evolve provides, and the clients live in the facility for anywhere, typically from 30 days to 90 days. All right, so at this point, I am going to hand it over to Caitlin to talk a little bit more about risk factors, triggers, signs, symptoms, and assessment.
Thank you, Rachel. As Rachel just stated in the statistics, adolescent suicide is very prevalent and extremely important for us to discuss as clinicians and continue this ongoing education. As we go into the risk factors, I do want to recognize this is a very heavy and important topic. It's essential that we're able to know how to spot it and how to navigate it if and when it does arise. So when we talk about suicide prevention, it's important to distinguish between risk factors, warning signs, and triggers. They're not all the same. And so typically, risk factors are long-standing or ongoing conditions or experiences that make someone more vulnerable to the suicidal thoughts or behaviors. And so I want to highlight, these alone don't mean someone will attempt suicide or are even experiencing suicidal ideation, but they do increase the likelihood that someone might struggle with the thoughts, especially when stress arises and builds up. So for our teens, some common and impactful risk factors can include previous attempts. This is a very strong predictor of future suicidal behavior. It can indicate both high emotional distress and the capacity to act on suicidal thoughts. A teen who's attempted once may try again, not necessarily for the same reasons, but because they've crossed that threshold before. Another one is a mental health diagnosis, especially depression, anxiety, any trauma-related conditions, and comorbid diagnoses like depression and trauma further compound suicide risk as well. When a teen is battling both, it's not just emotional pain, it's a reduced ability to cope or see a life worth living. For trauma, teens may experience emotional dysregulation, dissociation, or even re-experiencing symptoms, all which can correlate with suicide risk. Trauma doesn't just impact how teens feel, but also it impacts how safe they feel in the world, how safe they believe the world is, and how much they feel they matter in it. Having a family history of either past suicide or mental illness, this can reflect both genetic vulnerability and environmental exposure. So, for example, if a teen with a parent or a sibling that they lost to suicide may also struggle with survivor's guilt. As we know, bullying is a huge one as well, especially when it's chronic cyberbullying. I'm going to get into that a little bit more later on. The loss of interpersonal problem-solving skills. Many adolescents lack the emotional tools to manage rejection, failure, or even conflict, whether it's peer conflict or family conflict. Without those skills, even those everyday stressors can feel very overwhelming. This can lead to impulsive behavior or thinking like this will never get better. And for some, it's not that they don't want to cope, they just don't have the skills to or haven't learned how yet. Heightened social stress, especially in adolescent girls. Adolescent girls in particular face heightened emotional sensitivity to peer dynamics and social exclusion. With social media, academic pressure, and body image issues, this can amplify distress. And in fact, this group alone is showing rising rates of suicidal ideation and ER visits for self-harm. And then lastly, we have youth of color or those in the LGBTQ plus community. These youth often experience, systemic discrimination, identity-based rejection, maybe barriers to affirming care. And this risk is further heightened when they experience family rejection or a lack of a safe space to go to. So, while these risk factors do give us a broader understanding of who may be vulnerable, they don't always tell us when someone is in crisis or in imminent danger, we might say. Right? That's why it's just as important to continue looking at all of the different warning signs. So I'm going to go into some emotional signs that you might see. These things can be subtle and sometimes dismissed as typical teen behavior, but can point to deeper distress. So for some teens, we might see them expressing hopelessness or worthlessness. And this can look like them expressing that they see no future for themselves, or feeling trapped, or feeling that things will never get better. And this is a major red flag, and I think can be one of the strongest emotional predictors of suicide risk. Apathy is another emotion that can come up. Sudden mood swings. A teen might go from sadness or anger to a sudden calm, and that might not always mean they're improving. So it's always important to explore any sudden or uncharacteristic changes in mood, and especially with our teens. Their moods are shifting quite often, and so we don't want to always assume or attribute that it is normal teen behavior or even developmentally appropriate. Intense emotional pain or numbness, increased anger, irritability, or agitation. We often will associate suicide with more sadness or withdrawal, but many teens can actually show risk through anger or defiance or agitation. And that can be their way of externalizing some distress that they might not know how to process. Feelings of being a burden to others. So, teens may express guilt, say things like, I'm just a problem for everyone, or believe that the world around them would be a better place if they weren't here, or that others would be better off if they weren't here. And this belief can be also deeply tied to suicidal thinking. So, these emotional signs, they might not always show up so clearly. That's why ongoing connection and open conversations are crucial. If something feels off, you want to trust your clinical intuition and ask those direct and compassionate questions. We would never just assume that that's all it is. So I'm going to go into some, behavioral signs. We also want to stay alert for these. And these are things that we can observe in how the teens might act. And these signs can often appear before they're even able to verbally share how they're feeling or express what they might be experiencing. Especially with our teens that might feel overwhelmed or are trying to hide their distress, or maybe they don't know yet how to effectively talk about it just yet. And so some behavioral signs might be talking about death, dying, or suicide, whether it's casual or not, just the mere action of bringing it up, giving away personal belongings. Teens who are thinking about suicide might be giving away things that matter to them, and that would be a sign that you want to look out for. Writing goodbye letters. So this could be saying things like, you don't have to worry about me anymore. I just want to say goodbye. If you're getting concerning text messages or voicemails, right? It doesn't have to be a full letter that is written down. It could be these statements that are put somewhere for, people to get. Withdrawing from friends, family, and activities, this increased isolation, and I think also ties into the loss of interest in hobbies or school or future plans that they once might have had. And this could look different. It could look like pulling away from friends. It could be pulling away from family, school, activities they once were a part of. And this isolation might be intentional, or it also could reflect a loss of energy or, tied more into depression and things like that. We have risk-taking behaviors as well. So this could look like reckless driving, unsafe sex, heavy substance use, picking fights. And, this might not just be, again, normal teen behavior or acting out, right? This behavior can reflect a strong disregard for their own safety, and for some, even a passive desire to be harmed. For increased use of alcohol or drugs, this might come up too. Experimentation is common in adolescence. However, when there is a spike in alcohol or drug use, especially paired with other signs, this could also be a way to numb any emotional pain, or even be used as a coping mechanism to lower urges to act on suicidal thoughts, or an attempt to try to push away or numb. If there's ever searching for a means to die, if there's any online searches, collecting pills, this behavior indicates that they have likely moved beyond ideation and even into planning, which significantly increases risk. And so again, whether it is found or they share this with you, it's something to take very serious. A decline in school performance or decline in overall functioning. So if you see this, sudden drop in their school performance, if they are missing classes, skipping school, quitting teams that they were a part of or clubs that they used to do. Or you see the other decline where they're failing to meet personal hygiene needs. These can be strong indications that they are struggling beyond the normal ups and downs, especially if it is persistent and continuous. So going into some, physical and verbal signs, this can also show up in physical symptoms, especially with teens who might struggle to recognize their own emotional states. So some of these could be changes in eating or sleeping habits. So either sleeping too much or experiencing insomnia. Here at Evolve, I've worked with teens that might say that they stay up all night thinking, or they want to sleep because they want to avoid their emotions. And it could be an escape for them as well, which is a form of an emotional shutdown, not eating or any significant weight changes as well. A neglect of their personal hygiene or appearance. Teens who stop bathing, they're not changing their clothes, they're not brushing their teeth. Again, that can be more than defiance or opposition or, what some might consider laziness. Again, teen behavior. That can be a sign of emotional exhaustion or disengagement. And I actually think this is particularly concerning when it is a change from their baseline, when you've seen a shift in this, when they once were able to perform these things, with or without prompting, but they were able to do it. And now it seems that it is persistent and they cannot. Frequent headaches, stomach aches, or other unexplained pain, these might be some psychosomatic complaints. And I think repeated complaints of not feeling well for whatever that might be, whether it is a headache or a stomach ache, can be expressions of more psychological distress as well. Fatigue or low energy. So you might hear phrases like, I'm just tired, or you see them really dragging throughout the day, really struggling to get through the day. This chronic low energy is usually more than just being overworked. It could be a signal of underlying emotional shutdown or a loss of will to engage with the world. Self-harm, if you observe any self-harm marks, again, these are physical signs to look out for. Again, self-harm alone might not necessarily indicate that there's suicidal ideation. However, it is a sign that you would want to inquire further about. You might hear some verbal cues, and these could be at different, levels. This could range from the, passive ideation to active ideation, but things like, I wish I could go to sleep and not wake up. Everyone would be better off without me. What's the point of this? Or you don't have to worry about me much longer. Any joking or talking seriously about suicide or self-harm is something you would want to go into further in assessments. I think these statements, even when passive, again, we want to take very serious because they can also reflect ambivalence about life. Any statements that are self-deprecating or shame-based language, like I'm a failure, I ruin everything, might also seem like low self-esteem, but they can also point towards suicidal thoughts, again, especially when persistent or escalating. So, when these statements arise, we want to lean in with curiosity, with compassion, not just assume it's, normal teen behavior. So now we're going to talk a little bit more about triggers, and these are specific events or experiences, different stressors that can activate or escalate suicidal ideation, especially with teens who already carry some level of vulnerability. So it's important to note with this that, these triggers are not always the root cause of suicidal behavior, but they're often the one thing that might overwhelm their existing coping capacity. For emotional triggers, something that we see often breakups or rejection. And this is not exclusive to just, a romantic partner. This is friendships. This is social exclusion. Adolescents often experience their first romantic relationships and, breakups can feel like a devastating loss rather than, temporary setback. And so rejection in the youth can feel very permanent for them in those moments. A fight with a parent or a peer, Conflict with parents or close friends can result in feelings of being misunderstood, unloved, alone, and they might perceive just, a singular fight as the end of a relationship because maybe quote unquote they feel they've ruined everything. Humiliation or public embarrassment is another one. Public shame, especially in schools or online, like cyberbullying, can feel very overwhelming for teens whose identities are still forming. Adolescents we know, are more sensitive to peer perception. And so embarrassment can lead to intense self-loathing and more social withdrawal. Any recent disciplinary actions, consequences like suspension, legal trouble, being grounded can feel like huge life derailments for teens. So they might feel like they disappointed others around them or truly believe that there's no way to fix their mistakes, like there's no coming back from that. So these experiences can lead to feelings of shame, rejection, helplessness, which in the mind of an adolescent might feel inescapable at times. For example, like a breakup might not seem like a serious issue to an adult and maybe something that we might consider even minor, but to a teen who's already struggling with depression or low self-esteem or family chaos, that breakup can feel catastrophic. Moving on to the traumatic and stressful experiences. So abuse, right? This is not just one type, but emotional abuse, sexual or physical. All forms of abuse are strongly correlated with higher rates of adolescent suicide. I think, emotional abuse can often be overlooked and is just as damaging as, physical or sexual abuse. Um, Sexual abuse does have one of the highest associations with suicidal ideation due to its violation of, bodily autonomy and the shame that's often internalized by survivors. And physical abuse does contribute to chronic states of fear, hypervigilance, and can contribute to feeling powerless. Any witnessing or experiencing violence. So exposure to violence, whether it is in the home, in school, in the community, we know that it can lead to vicarious trauma, PTSD, and especially with our youth who are not equipped with these coping strategies or lack the support systems, whether at home or at school. Bullying and cyberbullying, which is becoming more and more prevalent with teens' access to cell phones and social media. With this increased access that they have to social media, adolescents can be subjected to constant comparison, harassment, exclusion. And I think cyberbullying is uniquely dangerous because there's a loss of safe spaces. It can happen anywhere. Even going home, they could still be being bullied through social media, platforms and all of that. Displacement from the home, example, like going to foster care. So I think, this often includes more of a complex history of trauma, neglect, and attachment disruption, but displacement can lead to fractured self-identity and instability with relationships and can create a deep sense of not belonging. And so any constant transitions with adolescents moving into new homes, new schools, new caregivers, can also reinforce some beliefs of feeling unwanted or unlovable. And then we have more chronic stressors. So these are things that are ongoing and long-term. Some chronic stressors are family dysfunction, so instability in the home due to conflict, parental substance use, divorce or separation that might be occurring. High conflict households can leave adolescents feeling hypervigilant and even withdrawal, increasing feelings of helplessness, hopelessness, chronic stress. And I think especially if it is, divorce or separation, whatever it might be, any of these, the substance use, they can internalize these factors and it could lead to guilt or shame or belief that they are the problem, which can fuel that ideation. We have identity related to stress. So those in the LGBTQ plus community or culture isolation. The minority stress theory does explain how chronic exposure to stigma, discrimination, or rejection can lead to to mental health risks. LGBTQ plus youth in particular do experience a higher rate of suicidal ideation and attempts, especially when lacking family or community support. Ongoing academic pressure or struggles. So the pressure to excel can lead to perfectionism, anxiety, burnout, and in some cases, increased ideation, particularly when the failure is perceived as catastrophic. Chronic medical illness or pain. I think these youth often face limitations in their independence, their social engagement, future planning. All of this can affect their sense of agency and hope. And then long-term social isolation and loneliness. And this can lead to feeling invisible. Long-term loneliness, I think, disrupts developmental milestones too, such as forming their identity, intimacy, relationships, autonomy, all of that. So, all of these, long-term stressors, they may not lead again to a crisis or imminent danger overnight, but they can build up internal pressure. And I think especially when the protective supports are missing or lacking, these things can definitely escalate quickly. So, these signs don't always mean that anyone is actively planning suicide, right? But they're important indicators of emotional distress, and they should always prompt further assessment. It's rarely just one event. It's usually layered on top of chronic stress, illness, mental health challenges, relational instability. So, it is our job to recognize these warning signs and triggers early when they do come up, not assume that it is nothing or again attributed to normal teen behavior, and know when and how to assess when that comes up. So yeah, I'm going to move on to the assessment slides. So I think first and foremost, when it comes to assessing, as a clinician, you are going to have your own emotions that might arise when something like this comes up. Whether it's your first time or your 100th time in this situation, you are going to have your own emotions. And I think it's so essential that we remain calm, we remain non-judgmental. We want to use the non-judgmental language. And we want to normalize open dialogue. Many therapists might worry about planting the idea if they ask about suicide or suicidal thoughts. And research shows that asking them directly does not increase the risk and, in fact, can be life-saving. So, again, it's important to know as before we go into each of these that all suicidal ideation is not a crisis moment. It does not mean they're in imminent danger and they need to be hospitalized because they've disclosed experiencing suicidal ideation. That is why the assessment portion is so crucial. If hospitalization, of course, is necessary for immediate stabilization due to this client being in imminent danger, then that's what needs to happen. But we also don't want to go and jump straight to hospitalization if that's not necessary. So when it's not necessary, we don't want that to become a pattern that this teen is now in. So first, assessing risk. It's been, it's there. We now know that this, client might be experiencing suicidal ideation. And we want to understand what is the frequency, intensity, what is the duration. We want to know, are these thoughts happening occasionally? Are they constant? How strong are they? Are they overwhelming? Are they fleeting or are they lasting for hours or for days? Is it persistent? We really want to understand how much time they are spending having to navigate this and how hard it may be for them to navigate these thoughts. Because there isn't just you have the thoughts and that's it. They're going to range depending on the client. So once you've, inquired more about the frequency, intensity, duration, you want to look into, is there the presence of a plan? Do they have means? And is there intent to act? Just kind of breaking this down a little bit when we talk about a plan. We want to know, have they been thinking about how they might do it? And it means asking them, I hear you've been having thoughts of not wanting to be here anymore. Have you been thinking about how you might do it? Or is there a specific method you've been thinking about? You know, examples that they may say that could indicate a plan may be there is I take a bottle of pills from my parents' bathroom, or I've looked up how to tie a noose, or I would crash my car on purpose. I jump off the bridge right by my school. You know, these are all plans. When it comes to the means, right, this is where we want to know if they have access to the things they would need to carry out these plans. So some examples they may say about this are, yes, I know where the pills are, or my dad's gun is unlocked in the garage. I've been cheeking my medications and I have them all stashed up in my room, right? We want to know about means because the more realistic and accessible, the higher the risk. So lack of access can be a barrier, but it's not always a permanent one. We want to ask whether or not they've made effort to gather means. So if they say they have a plan to hang themselves, but don't have anything to do it with, that doesn't mean there's no risk right there or that it's still not high. We want to inquire, we want to ask, are you planning to obtain that? Are you planning to go out and get that? And then intent. So this is, are they wanting to act on it? We want to ask if they would go through with it or if they think they would go through with it. I've asked clients before, on a scale of 0 to 5, how likely are you to act on these thoughts? And some examples indicating intent could be, I've been waiting until no one's home so I can do it. Or I'm just trying to find the right time. Or I've been writing letters to people to say goodbye. Or even, I don't know if I want to die. I just want it to stop, right? We have to remember intent isn't always overt. So it might not be a flat out, yes, I'm going to do it. It could fluctuate. Intent does fluctuate, especially in adolescents with mood instability. So, intent is also not based on their intensity. They may be crying or screaming or seemingly distressed, but that doesn't necessarily mean they're at a higher risk, and vice versa, right? If they are more, subtle and quiet, that also doesn't indicate low risk. That's why we have to ask the direct and detailed questions. Even for me, like in fact, I feel more, personally vigilant around those teens that seem just a little bit too quiet. And then we want to inquire about the level of lethality of these plans. What is the likelihood that what they want to do would be fatal? An overdose with high lethality drugs is different and potentially fatal, right, compared to a non-lethal self-harm, for example. And I think it's important to note a lot of the times these teens don't understand lethality. So part of our role is to assess their understanding of what they're planning to do, especially, right, if we have a teen who, and I'm going to kind of go into this a little bit more when it comes to level of ambivalence, but if their intent isn't to die, right, but maybe their intent is to escape pain and they're acting on this, like all of that matters. So we need to make sure that they know what they're planning to do and that we understand the level of lethality so that can inform our next steps. The level of ambivalence, so the desire to die versus the desire to escape pain. Many suicidal teens will experience a push and a pull between wanting to die and wanting relief. And, sometimes it might just be about wanting relief from the emotional pain. And sometimes it might be because they want to truly die. And we have to be able to ask those questions as well and get further into that, because if it is that, it's the desire to escape pain, it's going to, help us navigate our next steps as well. A history of prior suicidal ideation or self-injurious behavior. So a recent attempt or frequent self-harm might suggest that they might be closer to acting again under stress. And it's important, we need to know what they've done in the past. What have they attempted? Are there co-occurring factors? So such as psychosis, substance use, certain diagnoses, even like bipolar disorder, right? Like we know risk is elevated when suicidal ideation occurs alongside things like command hallucinations or delusional beliefs. Substance use we know can lower inhibition and increase impulsivity. So we want to consider and assess whether judgment and reality testing are impaired. So again, when assessing risk based on ideation alone, we have to move beyond, do you feel suicidal, to asking more questions, doing our assessments. More details are needed than just that. And it can't just end there if a client shares that they're suicidal. We have to follow up with all of the necessary questions. I think a strong assessment, it never relies on just one question. It comes from a very, very thorough and structured exploration of all of these risk factors as well. So, how would you assess after a suicide attempt? Again, I think to start it is we want to remain calm and we want to remain non-judgmental. We want to evaluate their current mental status. We want to know about their insight and their feelings about it afterwards. And so I think, beginning with a clinical mental status evaluation, we have to know, are they oriented? Are they coherent? Are they emotionally regulated? What is their insight into the attempt? Do they understand what happened? What are they feeling? Are they experiencing regret, shame? Do they have relief? Or are they continuously still feeling hopeless? Like, do they wish it did work and it didn't? We have to know how they feel about what happened, and we have to ask them if they still are feeling that way. It's essential that we understand what the precipitating factors to that attempt were, and are they resolved or are they ongoing? So we have to identify this, the events, the stressors, or the emotional states that led to the attempt. Was it impulsive? Was it planned? What was the trigger? Was it a breakup? Was it family conflict? Was it a traumatic memory? We have to know what occurred, and we have to ask and understand, are those stressors resolved or are they still active? If they're unresolved, then risks still may be very high. We want to explore the method used and its lethality. So this gives us both insight in intent and danger. Did they believe that this method would be fatal? Was it chosen impulsively or after research? How lethal was it in reality, right? Rachel gave some examples earlier. For example, and this is another one, like overdosing on vitamins is far less lethal than a hanging or a gunshot, but intent still matters, even if the method was non-lethal. We want to assess for continued ideation, intent, and access to means. So we have to ask very clearly about current thoughts, plans, and means. This could look like, do you still have thoughts of ending your life? Do you feel safe right now? Do you still have access to the things that you used? We want to also, consider the history of previous attempts or non-suicidal self-injury. Rachel's going to get into this more, but again, assessing after a suicide attempt, we do want to weigh in the presence or absence of protective factors, and again, level of care consideration at that moment, which Rachel's going to get in more detail later in the presentation. So a post-attempt assessment is not just about what happened. It's about what the risk looks like going forward. Some clinical considerations to take in, suicide risk is the highest within the first 3 months after discharging from inpatient psychiatric care. The first week post-discharge did have the highest risk, but that 3-month window was consistently critical across multiple studies. And this is all even if a client or a patient leaves and is discharged and it seems like they were stable. Even if they seem stable, these statistics still are very relevant. And so that is why it's so important to ask about past attempts, about when the last attempt did occur, so that way you have a better picture of the level of risk and how to proceed moving forward. I think let's So I'm going to talk a little bit about the Columbia Suicide Severity Rating Scale. So here at Evolve, this is one of the tools that we use to assess our teens. This was developed in 2007 by researchers at Columbia University as part of a larger effort to standardize suicide risk assessment in both the research and the clinical setting. It was also developed with the funding support from the National Institute of Mental Health. And it was originally developed for use in clinical trials. And since then, it has become one of the most widely used tools worldwide for assessing suicidal ideation and behavior. The Columbia Lighthouse Project does oversee the scale at this time, and both the protocol and the training on how to use it are provided free of charge for the community and healthcare settings and can be integrated into any EMR system that you have. And you can access this directly from the Columbia Lighthouse Project official website. It helps you identify how serious a person's thoughts or behaviors are. Everything that we kind of spoken about, it goes into their ideation, intents, plan, behavior, lethality, all of those different components. It is used in clinical settings, community research settings, and it uses simple questions to understand, are they thinking about suicide? Do they have a plan? Have they tried before? And it can help, as professionals decide what kind of support might be needed. And it can guide whether immediate help, like a hospitalization, is required. So these are some of the components, again, in the scale. It's going to look at suicidal ideation, both passive ideation and active ideation. The intensity of the ideation, so again, frequency, duration, controllability, deterrence, reasons. So, the deterrence, like what is going on in that person's life that could potentially, deter them from acting on certain things. What sort of reasons do they have for wanting to die? It goes into suicidal behavior. So any past attempts, like actual attempts, aborted attempts, interrupted attempts. So aborted attempts meaning, if maybe they began to do something to end their lives and they stopped themselves before acting, or actually following through with it. Or an interrupted attempt, like they began to do something to end their life and someone else or something stopped them before they actually acted. Any preparatory behavior. So we're going to ask them if they've ever done anything to prepare. Have they collected pills? Have they been giving away valuables? Have they been writing suicide notes or goodbye letters? Anything in preparation. And then it's going to go into the lethality of attempts, past or potential plans. So again, we want to know what was the actual lethality of it? What was the medical damage? What was the based on the method used? It is a very comprehensive assessment. It really does cover so many of the different bases. Again, like although you have this great tool and it is helpful in making sure that you are covering so many different components and it can really help you gauge where the client is at, it is still the tool and you are still asking these questions and still having open dialogue and conversation with the client. I think it's about understanding the severity and the urgency, and it does focus on different dimensions of risk. And I think this really helps give you a better picture on how to guide your clinical decisions, your documentation, and your next intervention strategies. I think one of the strengths of this scale is that it differentiates between passive ideation and active ideation. It's really important. But ultimately, once you've completed this assessment, it is still up to the judgment of the clinician to decide and then take actions on the next steps based on that. So I'm going to pass it over to Rachel to begin discussing interventions and responses.
Thank you. All right, I'm looking at the time. I'm noticing we're just about halfway through the presentation, and I know it's only 2 hours, but it is a heavy subject matter. So, and some of you might also just be sitting with like post-lunch lull energy. So, just inviting anybody who needs to. I can't see you guys, so do whatever you need to do, stretch, like stand up, whatever you need. All right, so we are going to be moving into interventions and responses, and I'll try to go slow and also just sort of pepper this with a lot of examples and just what this might look like in the clinical realm. So when we approach suicidal ideation in our offices, regardless of whether those offices are in private practice, in a treatment center, or residential care, it can be really helpful to triage interventions into a couple of different categories. And for the purpose of this presentation, we're going to talk about the crisis or imminent danger category and the non-crisis, non-imminent danger category. And I'll say a little bit more about that languaging in a second. But so first, we're going to talk about crisis situations, or a situation in which a client is in imminent danger. So in terms of immediate short-term responses, this first one might be a little bit of a surprise, maybe not to some clinicians, but the first stop along the way should always be validation. And by this, of course, I'm not talking about us supporting anyone's desire to end their life, but we are oftentimes seeing clients potentially in the darkest moment of their life when they are experiencing active ideation. And our ability to meet them in that place is going to directly correlate to our ability to help support and also get the information that we need in order to support this client. So what I mean by that is being able to, one, thank your client for sharing the information that they've already shared with you. Communicating, I would say to a client, thank you so much. I'm really touched that you chose to share that vulnerable information with me. I can only imagine how hopeless, helpless, trapped, powerless, scared, whatever the, feels like it suits the situation, you might be, and I want you to know I'm holding space for you right now. If I were to skip that and go straight to go, intervene, crisis, I'm on the phone making plans mode, I will visibly see my client shrink and withdraw and shut down. So we want to really prevent that from happening. Just because it's a crisis doesn't mean that you can't be slow and intentional. So next, I want to talk a little bit about assessment. So Caitlin already covered a lot of the specific details and nitty-gritty of assessment. I just, again, want to point out that curiosity is the name of the game here. And also just, being a little bit fearless in terms of your questions. If you're confused, if a client gives a vague answer to a question, sometimes when I'm working with a client says something vague and I just sort of let it go. And I think, well, we'll address that next time. And this might be a situation where you're not going to have the luxury of addressing it next time. So if a client shares something that I feel like is somewhere in between, I'm not sure if it's passive or active ideation. Like, I don't know, I'm thinking, let's just say a client says something like, I've always thought it would be so beautifully tragic to die by drowning myself in a swimming pool. I don't know what that necessarily means. Is that person, having active ideation? Is that person having passive ideation? And I don't want to make any assumptions. I'm going to start asking questions like, can you tell me a little bit more about that? Has that been something that you've thought for a long time? Is that a new idea? Do you have any intention of drowning yourself in a swimming pool? Do you have a swimming pool? Do you have access to a swimming pool? All of these questions. And it could be that you ask a follow-up question and they're just like, I don't have any intention of drowning myself. I just was reading this book and so, but clarify, get to the bottom of what they mean by that statement. Let's see, is there anything else I want to say about assessment? I think, maybe just the point is regardless of whether you're using structured assessment, like we use the Columbia here at Evolve, or whether you're using structured assessment that your treatment facility requires, or whether it's just a direct line of questioning that covers a lot of the bases that we've already talked about today. It doesn't matter. We're not here to say that one form of assessment is better than another, or one form of assessment is, I don't know, going to somehow miss something. It's really just you ask questions until you're satisfied that you have a good understanding of what's needed in this moment. Safety planning. Safety planning can look like a lot of different things. And, first and foremost, I just sort of want to say that in a crisis or a situation where there's imminent harm, this is likely going to require a breach of confidentiality, of that client's confidentiality. And, just as a reminder, our legal mandate, or your legal mandate as a clinician, is that in the state of California, if a client poses imminent danger of severe bodily harm to themselves or others, in this case, we're talking about themselves, then the law requires that we take action, reasonable action, in order to prevent that harm from happening. So I don't need to have 100% certainty that my client is going to try to kill themselves today in order to break confidentiality. Confidentiality is also not, sort of like all or nothing. If I am going to break confidentiality, I'm going to reveal, I'm going to be very specific about who I'm speaking to and give them, the information that I think they need in order to help me keep the client safe and know more. And I'll give you a couple of scenarios that have come up in my own personal practice, or actually this was when I was working for an outpatient facility many years ago. At this facility, the clients had numbers that would directly go to the clinicians' cell phones. And I got a text at 2 a.m. in the middle of the night from a client telling me that he was standing on a bridge. And in that moment, my breach of confidentiality was to call 911 and report that the client was on the bridge, and then to be in communication about what that client's name was and where that bridge was. And then when the authorities went to the bridge and the client wasn't there, I also did provide them with the client's home address in order to do a wellness check. So, breaches of confidentiality with teens usually look like contacting or being in touch with family members or caregivers, but not always. Another example is that I was working with an adolescent male who was just expressing a lot of chronic hopelessness and helplessness, and a very strong belief that nothing, was going to get better. And I was working with other clients actually when a message came through, and I just sort of happened to see the headline of it, which was, thank you so much for everything you did. It's been great knowing you. And that was the content of the text. But knowing what I knew about this client, I immediately excused myself and reached out to the client's parents and said, I just got a really concerning message from your son. Can you please, just check and verify that he's okay? And he was in a closet and had overdosed on his lithium medication. So, I think that sometimes, and I share these examples not as a scare tactic in any means, but to give illustrations of real life examples, because I think sometimes clinicians, you don't want to jump the gun. If a client is expressing passive ideation, you don't immediately want to call everybody that client knows and share that. But you also want to err on the side of safety. I will tell clinicians all day long, you should have, it's okay to have a client who's angry at you or a family who's angry at you. I would much rather have that than a dead client. So, just consider if you're worried or concerned, the law is there to protect us in instances where we break confidentiality in order to keep our clients safe. Safety contracts or contracting for safety. Again, this is something that in my experience, clinicians and clients sometimes like to poo-poo the idea of safety contracts because they are just a verbal agreement or a piece of paper that can be broken at any time. Absolutely, I do want to acknowledge that. And the mere act of engaging in contracting for safety, again, whether it's something written, we have something that we write up with the client, or if it's just a verbal contract, that again is also sort of part of the assessment stage because you're going to get really good information. And I think too, I want to say a little bit more about the coaching that is typically involved in that process of safety contracting or contracting for safety. Because, I'll give you some examples. I have counselors who do risk assessments for me with clients, and sometimes I'll get a phone call from a counselor saying, so-and-so wasn't willing to contract for safety. And I'll say, well, what does that mean? What did you propose? And they say, well, they said that they couldn't keep themselves safe. Clients will oftentimes tell you if the question is, can you keep yourself safe? They're oftentimes going to push back against that because it's sort of like, well, can you keep yourself clean and sober? Well, probably not forever. That's like something that they might not want to commit to. But you don't need a client to guarantee that they're going to keep themselves safe forever. You need a client who is willing to say that they can keep themselves safe for the next 24 hours until their parents come back into town. Or you need a client who's willing to say that they can keep themselves safe until 2 days from now when you have another session with them. Or that they are able to, if the client has a driver's license, that they are able to get themselves home safe where that their parents are and you've already had a conversation with their parents and they're going to receive that client. So, it's okay to just be very specific. Basically, the contracting for safety is around, can this client agree or commit to keeping themselves safe until we can metaphorically bubble wrap around them, or until we're able to secure a higher level of care, whatever that is going to look like. I will say if a client pushes back against any or all of those efforts, then that ratchets up the risk level considerably. And obviously, clients can and do lie to us. Teenage clients especially can and do lie to us each and every day. And in my experience, if you ask direct questions about their ability to keep themselves safe, they tend to be pretty forthcoming. Now, having said all of this, another step along with validation that we really don't want to skip here is identifying strengths and resources that are currently available. So this is speaking to both internal resources and external resources. So, ideally, you want to have a good sense of this client's ability to tolerate distress, this client's ability to be bored, to sit with boredom. And that might seem like a silly thing, but right now, especially, most of the clients that I work with have a very low threshold for boredom. They need to be distracted constantly. And we're sort of living in a world that, perpetuates that. And if I have a client who I know has some level of resilience, has gotten through really difficult things in the past, and has, been able to assign meaning to those experiences, who has an ability to tolerate distress, who has an ability to problem solve. Those are all amazing protective factors that help clients give pause to impulsive actions. Clients who can tolerate distress tend not to act impulsively, whereas clients who can't sit with any amount of discomfort, who sort of have a hair trigger for acting out or for distracting, whether that's, cutting or getting high or, driving too fast, whatever that is, the risk level is higher with those kiddos. And then similarly, clients who have, Caitlin mentioned this a lot, in terms of, does this client have hobbies? Do they have passions? Do they have things that they love doing? Doesn't really matter what that thing is. Do they have things that they're looking forward to? Do they have a network of social support? And when I say social support, I mean in-person, real life interactions with other people. I'm not talking about the client whose sole social interactions exist via a headset while they're gaming. These are not the same as kids who have friends that they feel like they can talk to, or not even friends that they feel like they can talk to, but friends who they have the experience of, feeling supported by, friends who they can go play soccer with, friends whose houses they can go over to when their parents are fighting, things like that. All of these end up serving as protective factors. And we just want to be conscious. It's all part of, it's all part of the picture. And then I just lastly want to say, these are resources that need to be currently available, right? So if a client has an amazing friend that they confide in everything to, but that friend is currently out of the country and isn't going to be back, for another month, then that resource doesn't count. And then appropriate referrals. What are the appropriate referrals in a crisis situation? A lot, when you're working with teens, a lot of the referrals are going to be for the family. But for the teen, we're going to be providing suicide hotlines. We're going to be, telling them about the 988 mental health crisis phone number. We, with the family, we're going to be looking into what a higher level of care might look like. Potentially making a referral to a pediatric psychiatrist. Also, maybe referring the parents to support of their own in order to, help sort of them navigate some of their own things that are being triggered, while they're trying to support their teen. Let's see, is there anything else I want to mention there? I'll come back to it if I think of anything. Long-term responses in a crisis or following a crisis. Oftentimes we as clinicians need to help facilitate a transition to a higher level of care and or the inclusion of additional care providers. And although this is listed as a long-term response, I do sort of want to, tie this into the short-term response, of making appropriate referrals. In my experience, when there is a crisis, whether there's been an attempt or a scare of some sort, once that, first couple of days, 40, 48, 72 hours have passed and things have calmed down a little bit, it's very easy for parents to, not intentionally or consciously, but relax and just assume that the worst is over. Because in part, they don't want to think that it's, they want to believe that it is. It's really scary for a parent to have, to worry that, their child is potentially going to kill themselves at any moment. And so it's pretty easy for parents to sort of sink into denial. And the reason that I'm bringing this up is because if we as a clinician believe that a higher level of care is necessary, then it is us doing our due diligence to make sure that that happens quickly. Because again, in my experience, and Caitlin, I don't know if you found this to be true as well, when that doesn't happen quickly, it oftentimes doesn't happen at all. And then we're back in this same place a month or 2 months later. Okay, so psychoeducation for the family is another sort of long-term response. So a lot of times this is, parents sometimes don't have any concept that their child was thinking about suicide or was planning an attempt for suicide. And so we want to educate the family on supportive, appropriate responses, responses that are going to engender openness in the family and not shut down and further isolation. We also want to provide psychoeducation about, appropriate next steps that families need to take in the home. You'd be surprised at how often I've had families, sort of push back a little bit when I talk about safety precautions in terms of locking up all sharps in the house, locking up medications. I've had clients, not clients, families say, well, do we really need to lock up the cough and cold medication? Yes, you do. Well, I have another, we have another younger child at home who likes to do arts and crafts. Do we really need to lock up, the scissors and, the art supplies for that child? Yes, you really do. So providing psychoeducation for the families can be really critical as well. And then, if you're working, this maybe comes into play more often in treatment centers, but, if suicide was not part of the treatment planning, was not part of the goal setting process when this client entered into your care, now it needs to be. So oftentimes there needs to be a reevaluation of treatment goals. And then, I want to just sort of, stop and mention that, although we're not here to say, one treatment approach is, far superior to another, I will say that, clinical research does fairly significantly point to dialectical behavior therapy as the number one treatment for suicidal adolescents. Now, that does not mean dialectical behavior therapy in the absence of other approaches. CBT, motivational interviewing, family systems work, all of those can be really crucial and supportive and effective when working with suicidal adolescents. I don't think this is a one-stop, do this and everything will be fine. We always have to look at the context and the systems in which our clients are living. But, it is important to say that dialectical behavior therapy was really designed, for very high risk individuals. And so if you are a clinician, regardless of what your approach is, and you find yourself working with high risk youth, it is to your advantage to get some level of training in DBT. And then ongoing assessment as needed. Again, once the crisis has passed, even once there's stabilization with the client, we always want to make sure we're going back and assessing and reassessing. And that doesn't mean each and every single session, although it probably will look like that initially, but just making sure to check back in regarding ideation, making sure, when a client has another big upsetting event in their life, that we're going back and we're checking in and we're asking about any thoughts that they might be having to harm themselves. And then lastly, and this is, it's last but not least, therapist self-care. Vicarious trauma is real. And we want to make sure, especially if you're somebody who works regularly with acute mental illness or, kids in crisis, your self-care is just, it's so important. So just make sure you have the self-awareness to know when you're reaching burnout. All right, moving into non-crisis. So I'm not going to spend a ton of time because some of the interventions are very similar. But if there is a non-crisis, non-imminent danger, these are the kiddos who oftentimes have passive ideation. They don't necessarily have a plan or means or intent. We still want to respond and make sure that we're doing a lot of the same things, maybe just a slightly different version of them. So our immediate short-term responses, again, are going to include validation. Thank you so much for sharing that with me. Wow. Tell me how long you've been sitting with that. It sounds really heavy. And then assessment. we're assessing, is it just passive ideation? Again, how long have they had that passive ideation? Has it ever gone beyond passive ideation? What is the history of, do they have a history of any suicide attempts? Is there a family history of suicide, completed or attempts? All of those things are really important in the assessment phase. For safety planning, it's very likely that if it's a non-crisis situation, a breach of confidentiality is likely not necessary at that moment. But we want to make sure that we're continually assessing should the degree of danger become imminent. And I'll give sort of an example that, I think highlights, the variation in what is a crisis. We had a client who was highly suicidal and actively wanted to kill herself, but her plan never changed, and the plan was non-lethal. And I believe her plan was to knock herself unconscious. And so in RTC, with 24-hour surveillance, that is not a crisis, believe it or not, because I know that if this client were to knock themselves unconscious, and I believe their plan was, to do so in the bathroom, I have a staff member on the other side of the door who's immediately going to open the door and call 911. Now, that same individual confiding that same plan to you in outpatient or private practice, that might be a crisis situation, right? Because maybe this adolescent goes home after school and then they're by themselves for several hours until somebody else comes home. So again, it's all about sort of, assessing for what is, this person's intention or lack of intention. Again, what are the strengths and resources currently available? What appropriate referrals might I need to make in this moment? And with a non-crisis situation, oftentimes it's helpful to do that sort of proactive planning on the back end, because if you have a client who's experiencing passive ideation, it's nice to identify the higher level of care or the resources or, the referrals that you're going to need to sort of leap into action on should that danger level increase. So I find it's really helpful to just have a plan in place should the ideation, worsen, because it's sometimes hard to think clearly in the midst of a crisis. And then long-term responses. So identifying, again, we talked about this just a second ago, but identifying next steps, higher level of care options, should risk level increase. Again, psychoeducation for the family where appropriate. You may not be, again, the family, depending on the level of ideation, may or may not be aware of the client's thoughts. But, maybe one stop along the way in a non-crisis situation is just, reacquainting the client with, this is something that I want to really, really be paying close attention to with you, because there are scenarios in which I would think it would be essential for us to involve your parents or your caregivers or whomever, in making sure that we can keep you safe. Again, possible reevaluation of treatment goals. And then similarly, just, the provision of evidence-based practices such as DBT, CBT, motivational interviewing, family systems work, making sure ongoing assessment. Again, a client expresses a lot of passive ideation, and then maybe the next time you see them, they don't mention it at all. Please don't assume that just because they're not mentioning it, that it is gone. We need to make further inquiry. And I find ongoing assessment is almost maybe, I'm not going to say more important, but it's still critical when you're dealing with the client who's, doesn't seem to be actively in crisis, because it can go either way very easily. And we just, for all sorts of reasons, and we haven't even, we're not, this is not the purpose of this training, but, a teenager's brain is hardwired for immediate gratification. It is not designed to delay wants or needs. And so, what is passive one day can very quickly become active another day. And then, of course, therapist self-care. This should be something that we are all doing regardless of whether we're working with suicidal clients or not. But, just it's a reminder here. All right, so Caitlin and I have talked for a long time. I'm glad to see that it's the time that it is because we wanted to do a few things once we were done, presenting this information. And one thing that we're going to do right now, we will look at a vignette, but before we go to the vignette, I'm actually just going to sort of pause and check out the questions that have been dropped into the Q&A while we've been talking. We'll address a couple of those, and then we will go into looking at a vignette together. Let's see, I'll look at the top two. So Anita asked, is cutting considered an attempt? Good question. Ask your client. The answer is maybe, but not necessarily, right? There are countless clients who self-harm on a regular basis, and it could be cutting. Self-harm burning is something that we commonly see. Also, just other forms of head banging is a big form of self-harm. And that's when we assess. We ask, was your intention to, what was the intention here? And there's a beautiful assessment. It's called the ISAS, the Inventory of Self-Harm. I'm not quite sure what Caitlin, I don't know if you know what the last S is, but it's, basically asking like clients assessing what the intention of their self-harm is. What is the self-harm designed to do? Is it to relieve pain? Is it to get attention? Is it to be a distraction from boredom? There's all sorts of reasons why clients self-harm, and we just want to make sure we're asking. Petia is my best guess, although I apologize if that is not the pronunciation of your name. Could you explain the difference between a desire to die and a desire to escape pain within the context of assessing risk? In which case is the risk higher? I would say that those are just opposite sides of the same coin. And that a desire to die and a desire to escape pain could very well be the exact same thing. But again, not necessarily. And I think all of these, this scenario as well is one in which I would ask further questions. When you say you just want to not be in pain anymore, can you tell me what you mean by that? Well, I'm just, I'm tired of waiting for things to get better. I will wait, but I'm so sick of waiting. There's a difference between that and, can you tell me what you mean, a desire to escape pain? And the client says, yeah, I just, the idea of dying sounds really peaceful.
Mm-hmm.
I
I
wouldn't.
think to add with that, Rachel, too, is, that's why it's so important to inquire about plans and means and intent, because a client might describe even a very strong desire to escape emotional pain very intensely. And as soon as you start inquiring more about plans, they may very quickly be like, well, I don't actually want to die. I just don't want to feel this way anymore. And that can give you a lot more information.
Yeah, thank you.
Mhm.
This isn't in our the open questions, but there was a really great one that I wanted to make sure we came back to, which is Jackie had asked about the possible involvement of AI influences. And Caitlin, I know you and I chatted about this yesterday or the day before that, but oh my gosh, it's such a great question, and I think it's a layered one because there have been a few a few articles lately that are quite concerning in terms of the impact that relationships with AI can have on mental health. I think that, and I'll just, and Caitlin, please jump in, but there was an amazing New York Times article that talked about, AI's, you know, it's brilliant and it is also designed to affirm and support what is being expressed by the person in communication with AI. And so, what I mean by that is there is a lot of mounting evidence to support that individuals with delusions, with psychotic disorders, with schizophrenia, with a desire to kill themselves are getting support, like getting validation for their delusion that they are, a godlike entity or that they should be engaging in these aggressive acts. There is actual, I've seen screenshots of AI saying that makes sense. It does sound like you are, X, Y, and Z and supporting the hallucination or the delusion. So it's scary. And I also don't want to dismiss that, there's a lot of people who find a lot of support and validation in the other direction from AI. But it's not harmless for sure. And I think, and this is the last thing I'll say about it, when we're talking about working with families of teens, one of the things, that families should probably be doing in addition to, locking up sharps and other things is seriously making restrictions on access to digital devices. And I always tell parents, like, there's absolutely no reason for an adolescent to have a device in their bedroom with them in the night. It's really, really dangerous. I've seen a lot of situations in which clients, are awake at night engaging in unsafe digital behavior that then leads to self-harm or suicide attempts.
Mhm. And with that too, Rachel, when we discussing the, warning signs and symptoms and things like that, especially those adolescents that are isolated and very withdrawn and not, spending time with peers, they do turn to that. And if they have access to it, they do turn to find comfort. Even here at Evolve, I've worked with teens that have experienced social exclusion and they've turned solely to the device, whether it is chats or meeting people, and it has really been, impactful on their overall mental health. So definitely something to keep an eye on.
Yeah, and I also just because this is such a big topic, I feel like we could talk for hours about this. I see a lot of parents who push back. Well, every time I try to take, the video games or the phone away from my child, they like explode. We see a lot of kids who get pretty aggressive with parents, and so the parent just like acquiesces or just gives up a little bit in order to not have those big behaviors. And that's where families really need so much support from us in setting firm and clear boundaries. And a child that can't handle having their devices removed from their presence is not a child who should just be given free rein with their devices. That is like that can sometimes mean that's a kiddo who needs a higher level of care. Caitlin, are there any questions that are jumping out at you that you want to answer before we get to the vignette?
Yes, there was one that I just saw. I'm trying to go to it regarding breaking confidentiality if the client is not in imminent danger. I'm trying to find this one. It says here, if a minor reports passive suicidal ideation with no imminent risk and you break confidentiality to inform a caregiver, are you still protected legally for the breach? I think that's a good one to answer. And I think there's a few things that go into that is if you are breaking confidentiality, ultimately you are breaking a level of potential, trust and rapport with that client. And so when they are not in imminent danger, um, and you still, break confidentiality, you do run risks of damaged rapport, damaged likelihood that this client will be forthcoming with you in the future, right? Or even continuous, therapy, let alone. But I do think to some level, when we are breaking confidentiality in good faith and there's reason to believe, you want to be safe with that. I think it depends on how, um, I guess, low risk it is.
Yeah, and it depends on, what when you say there's no imminent risk, like it depends on whether you're aware there's no imminent risk or it just turns out in the end there was an imminent risk, right? Like, because if you believe that there could be imminent risk, then you very likely are protected. But if a client is saying, well, sometimes I just wish I didn't wake up in the morning, and you break confidentiality to share that information with caregivers, then that probably wouldn't be protected. Um, in the example where I called the client's parents, do I stay on the phone until I know they have checked on the client? Not necessarily. Now I was able to reach the parent in that moment. If I hadn't been able to reach a parent, if it was just like if nobody was picking up, um, here's the reality. As long as we take reasonable efforts to keep our clients safe, then, and I'm not saying this in a glib way, but regardless of whether the client ends up being safe or not, then we are legally protected. Um, Now, in that moment, if the parent hadn't picked up and I knew where the client was, then I could have also called 911 and said, I need somebody to go to this place and this address. I actually didn't know where the client was because I had just gotten that text. So it was very fortuitous that I did get a hold of mom. How has the response to suicidal ideations and threats shifted with 988 not being implemented and with the shift away from law enforcement being involved in these situations? Oh gosh. It really depends, on where you live and what sort of resources are available. Like I will say that sometimes even when the call is made to 988 or a suicide hotline, sometimes the response is still law enforcement. And I, for example, I work and I run a treatment facility in Ojai, and the closest crisis response team is in Ventura. And sometimes, and I'm just speaking very plainly, sometimes they are willing to come and sometimes they are not. And so oftentimes, even if it's a mental health crisis, it is law enforcement that is being dispatched to that. So, in terms of like an overall, national shift, I honestly, I wish I wish I knew a little bit more about that. And I don't know, Caitlin, if you have anything you want to add. All right, there's so many great questions, and I really want to have a chance, and maybe this will answer some of the questions that are in the Q&A, to go through a vignette and just get a little bit more active involvement from you guys. So if we can go back to the PowerPoint and just bring up the vignette of Kyle, that would be great. All right, so I'll read it out loud. Thank you, Hannah. So Kyle has presented to individual therapy for assessment and weekly sessions. Kyle's a 15-year-old male living with his biological parents who are married. Kyle is a religious, high-performing student in school and appears outgoing and articulate. Kyle's parents share that they became concerned because Kyle's girlfriend told them that Kyle was considering killing himself. Parents state that they didn't even know he was depressed, but acknowledge that he's been a bit more distant and irritable. Parents ultimately set up therapy after Kyle was found self-harming with scissors in the bathroom at school, where his mother also works. Wounds were mostly superficial. Kyle is engaged but guarded in therapy. He states his parents are making a big deal out of something that isn't that bad. He admits he gets sad and feels depressed, but states his thoughts of suicide are passive and that he'd never do anything. He describes having thoughts such as, "This is too hard, I don't want to do this anymore, and I can't face another day." When asked about his relationship with his parents, he says there's nothing to talk about. So, Kara, are we able to open up the chat so that so that the participants can see each other's level of engagement or see each other's chats?
Yes, it is open.
Awesome. Okay. So we do have a slide that has the discussion questions, but let's just keep it on Kyle so that people can sort of um, look at the vignette. And I'm just going to ask questions, and I'd love to just sort of see people enter what their thoughts are into the chat. You know, again, this is not a like, there's a right answer and a wrong answer. This is just a common situation, and let's talk through it. So first question is this a crisis or a non-crisis situation? What are your thoughts? So I see a couple of crisis responses, but a lot of non-crisis. Non-crisis intervention is necessary. Non-crisis, non-crisis. So I would tend to agree that it is, sorry, I'm going to go back to my vignette. I would tend to agree that it is mostly a non-crisis situation. And whoever it was that said intervention is necessary, yes, 100%. And there are some, this is a client who clearly is endorsing passive ideation, who's also clearly saying parents are overreacting, I would never do anything. And there's some red flags here that would, make my spidey senses tingle, including that the parents had no idea that he was even depressed. Interesting that Kyle self-harmed at the school where his mother works. This is a kiddo who potentially is impulsive and who is certainly guarded and not being fairly forthcoming, right? This is a situation where, as a clinician, I would think, I don't know what the whole story is, but I certainly don't know what it is. Caitlin, what would you add?
Yeah, everything that you just said. I agree with the chat is, it's concerning and more information is needed.
All right, so the next question is, what do we think? Do we think that any breaches of confidentiality are needed in this moment without further information? Sorry, I'm trying to get not at this time. No, not necessarily. Not in this moment. Not without further info. More assessment needed. Cry for help. To tell his girlfriend. Yeah, right. Is like there's certainly a question there. Did Kyle think that his girlfriend would keep it a secret, or did he expect that she would share it? And kudos to Kyle's girlfriend, right, for not carrying that on her own. This is actually fairly uncommon. A lot of the times we have friends and girlfriends and boyfriends and partners who are just like, let me be your support system. So pat on the back to Kyle's girlfriend. Yeah, ask more. Yeah, absolutely. You guys are, right on it in terms of, there isn't anything pointing to imminent danger in this moment. So now it's on us, right? We're going to start asking the questions. And gosh, this whole thing makes me so curious about what's going on in the family. That, there's something in the vignette that I was looking at. Appears outgoing and articulate, but when you ask about his family, he says there's nothing to talk about. That's interesting. Next question, what safety planning is necessary? And this could include, a lot of you guys have mentioned it already. So, again, this could include structured or unstructured assessment. Let's assume that's going to happen because you've all typed that that's something that you would do. But what other safety planning might you engage in with this client? Because it doesn't sound like we're breaking confidentiality. Yeah, stay aware, listen. This
Removal
is,
of sharp objects.
yeah. What do you think about that, Caitlin?
Yeah, I think that's something that stands out to me here because, right, the parents um, found out that Kyle had been self-harming. So they were aware of the self-harm. I think it would be in their best interest to lock up sharps or remove sharps from the household. It
Yeah.
doesn't mean he can't go obtain them outside of the home, right? No, but that means that his home environment is more secure.
Yeah, 100%. We don't need to break confidentiality in order to tell the parents, like, your child has self-harmed once. Let's minimize their access to sharps, in the home. And it's also just, it's symbolic too, of parents making a response, and no kid is going to want that. And they also need to see parents taking what's going on for them seriously.
Mhm.
Yeah, exploring protective factors. Yeah, 100%. Like, removing sharps from the home does not mean removing access. Like, yes, anything can be used as self-harm. And this is part of the psychoeducation that we're doing with parents, and part of what we're doing to really uh, put in the mindset that this is something we want to take seriously.
Mhm.
Yeah. Um, Stop skill. Yeah, DBT. Let's bring in those DBT skills. Working to provide concrete tools and skills to help this client regulate themselves when they do, experience either hypo or hyperarousal. Yeah, looking at who the resources are outside of the girlfriend. Also, let's explore the girlfriend a little bit, right? Because, I've had worked with clients whose friends and romantic partners are major support systems. And then I've also worked with clients, and this happens a lot actually at Evolve. I know you've seen this, where we have a client and their romantic partner is also actively suicidal and is also actively depressed, and they together are like, see each other as, like, this ship trying to navigate the storm together, and meanwhile they both have like totally broken masts. Yeah, great. Okay,
Mhm.
great ideas.
Yeah.
Let's move on to the next question. What might parent coaching look like? Multifamily skills group would be super helpful. I agree. Why aren't there more of those? Um, Psychoeducation, yeah, support group for parents. Um, this is moving around so quickly, but somebody just said warning sign, like
Yeah.
something about warning signs. Yeah,
Yeah. Psychoeducation about warning signs.
yeah, right. Because these are parents who are like, there are always warning signs, and these are parents who are sort of missing them right now. Family sessions, psychoeducation support. Yeah, is family therapy being done presently? Because if not,
Mhm.
certainly sounds like it's necessary. Yeah.
So I think exploring that parent-child relationship.
Mhm.
Again, it sounds like there isn't much communication regarding emotion that I'm gathering from this with
Mhm.
him and his parents.
Mhm. Mhm.
It states his parents are making a big deal out of something that isn't that bad.
Yeah. And good for the parents for making a big deal out of
Mhm.
this. And um, 9 times out of 10, teenagers feel like they're speaking a different language from their parents, even though they might all have the same goal. So, really just trying to, get this family on the same page and speaking the same language. Yeah. Yeah. And some of that, some of knowing what parent coaching is necessary is going to be that further exploration of family dynamics with the client. What is, like, as somebody here mentioned, like, what's going on behind closed doors, or what does its dynamic look like? Um, it certainly seems like they have a lot of strengths and resources, and something here is going on, and being able to figure that out a bit with the client so that then you know how to approach the family compassionately. And then the last question, what are like, so this is a client who presented for, I'm just going to assume like weekly outpatient therapy, yeah, weekly sessions. Um, what do you all think is an appropriate level of care, or an appropriate, what does appropriate treatment look like in this situation? Yeah, definitely. Carrie, I want to acknowledge your comment about family culture and family background playing a huge part. Also, just their involvement in religion can be a massive, support system for the family and for the client. Um, Comprehensive DBT, possibly IOP, outpatient treatment. Yeah, motivational interviewing. Weekly sessions are appropriate, but there clearly needs to be more rapport building. Cognitive restructuring, IOP. Yeah, so it seems like everybody's sort of, on the same page. We're looking at like outpatient IOP options. Nobody's really mentioning residential care or PHP or hospitalization at this time, and I think that's appropriate. Um, Caitlin, I don't know if you want to jump in and comment on like, outpatient versus IOP.
Yeah, I mean, I think too, like with the vignette as it is with this information, I agree in terms of an IOP program where it is after school and he's still attending school, but increased sessions. Um, I think though, if you were to take this vignette and ask some more questions regarding even the self-harm, right? Because early on it states that there was the girlfriend mentioning he had considered killing himself. So this could drastically shift if you do follow up, right? Which all of us would in that moment of, are there actual plans? Has he ever considered plans? Has there been research into plans?
Mhm.
And additionally, looking at the self-harm and inquiring of what's that, with the intention of wanting to die. Those, that can really then shift our lens in understanding what is the level of risk that they're at. Because if after that assessment, you see that maybe this client Kyle has actually had a self-aborted attempt a week ago, right? Maybe he actually did take steps to come up with a plan and try to kill himself, and maybe was about to begin doing something and he stopped himself, or the girlfriend interrupted, right? That could then shift. Maybe IOP might not necessarily be most appropriate if there really was an aborted attempt or an actual attempt right prior to that. That just wasn't talked about yet. So I think again, this does set the stage. And if this information alone, yes, maybe IOP or even outpatient potentially, but once you've inquired more, and that could shift things for sure.
Yeah, and it could also be that part of this process is like really sort of coming up with a plan with family of, or not with family, but with the client, just saying like, I like to be transparent, and I think we should all be probably more transparent with our clients in terms of like what we're thinking. If I am if I think, if X, Y, or Z happened, then I would refer my client to a higher level of care. I'm going to be fairly transparent with my client about that. Um, and, sometimes we feel like that's going to promote secrecy. But, in my experience, honesty and transparency with clients is, builds a lot of trust. And maybe even that speaks to what level of care we're going to recommend. Is this a client that we feel we have a very strong rapport with and a really good relationship where we feel pretty confident that the client is going to share with us if there's an increased level of risk? Or is this a client that, um, tends to be very secretive and very guarded, and we have no confidence level at all in the client or maybe in our own ability to deal with it, then that might also dictate what we're going to refer. Can we provide family therapy? Is the family willing to go to family therapy? All of these things. And again, I love everybody's reading about everybody's thought process in the chat, because I think, ultimately, we as clinicians, we live in shades of gray, and we live mostly trying to convince our clients that not everything is black and white. And so being able to just live in that gray area where, there's not one right specific answer. It's just, this is the best, we're going to do today based on the information that we have. And when the information changes, our assessment might change as well.
This is a good one. How do you adequately assess an adolescent client if they avoid questions about intent? If they say, I don't know, I'm not sure, maybe. I think this is a big one and is more common in adolescence than, those might think. Like we said, intent is not always overt. And so if you have a client where you're trying to assess, intent, and they're saying, maybe, I don't know, maybe, right? We want to look at the full picture. We also want to know, well, what is their plan that they're potentially going to act on? And what is the means to that? Like, we want to know, do they have all of the other things to potentially, act on this, again, potentially fatal attempt versus a client that might say something along the lines of, maybe I'm going to, I'm going to kill myself and, I'm going to strangle myself with my hands, right? But they might say, I don't know if I'm going to do it. I might, maybe. So what we know, right, is that you can't, it's usually not fatal, right, to strangle yourself with your hands. And that maybe they pass out. It's not a good thing, right? Is that the same lethality as jumping from a large building? No. So taking that into consideration too, and if that is all that client is truly planning in that moment, that's all they're endorsing, I'm not going to, I think, freak out or get too stressed if they're like, maybe, right? It is also weighing in all of the other factors at play with it too.
Yeah, and I think too, just, I want to acknowledge, Daisy, that teenagers are notorious at just being like, I don't know, like maybe, I don't know, and maybe we don't even know as much as the plan, right? Maybe it's just like, have you ever thought about killing yourself? I don't know, maybe. Sometimes that is really all we get, and we aren't. We're not mind readers, and we're not supposed to be mind readers. And we do our best to prevent harm from happening, but we're also not going to leap into action if there's no information to be had to leap into action, if that makes sense. If all the client is saying, I don't know, maybe, we're going to keep digging and we're going to keep assessing. Oh, sorry, somebody's at the door. But we're also not going to we're not going to necessarily act if all the client is saying is, I don't know, maybe. We're just going to keep assessing. There was a question about that I thought was a good one. Any strategies or suggestions for working with youth with autism, or ID? Why am I blanking on what ID is? I'm not quite sure, but with, autism spectrum disorder, who experience suicidal ideation. Yeah, I mean, a massive percentage of our clients are on the spectrum and neurodivergent. And, I will say that, in the last several years of working with these clients, there's some commonalities and so many differences in terms of cognitive processing abilities, in terms of impulsivity. We see a lot of clients. It's pretty staggering how many clients on the spectrum also have ADHD diagnoses and do struggle a lot with impulsivity. So, I think that really getting a sense of what your specific client, one, I keep saying the impulsivity thing. Again, if this is a highly impulsive client, I'm going to pay attention to that. I think also, again, this is not across the board, but a lot of clients who are neurodivergent tend to be more concrete and less able to engage in abstract thinking. And they tend to also be, hyper focused on immediate gratification. So if this is an impulsive client with depression, with passive suicidal ideation or active suicidal ideation, and they also see things in very black and white terms, I'm either good or bad, or, my life is either, good or it's shit, excuse my language, then, I think all of that, just the client's ability to process and the client's ability to access internal resources, again, tolerate distress, sit with boredom, all of those things are going to determine maybe how I'm going to respond to the client. I'll also say that at Evolve, a lot of my work with neurodivergent clients is with the parents and really educating the parents around the fact that their child is not necessarily just being willfully disobedient or aggressive or oppositional and defiant, that it is, quite literally an inability to tolerate distress in their bodies and a very, a lot of easy overwhelm from a sensory perspective. And, so we're looking at school and, what's going on at school and what's the right academic setting and what's the right support setting and really what parental responses are going to be the most effective. Do you ever feel that in an outpatient setting or really any setting that safety planning could give the family a fake illusion of control on preventing injury or death? Many times I've seen safety plans to include remove access to medication, weapons, etc., which makes sense. However, if there is a will to cause harm, a way can be found. Yeah, you're correct for sure. But in terms of the question, have we ever found that safety planning gives a fake illusion of control? No, I don't think so. And the reason that I think I'm saying that is because typically, in my experience, the families who are willing to engage in safety planning and remove risky things from the home and restrict their child's access to certain things or restrict their child's coming and going from the house, those are typically caregivers who don't tend to relax. Or they tend to just be vigilant across the board. It's oftentimes the families who are not really willing to engage in safety planning or unfortunately, we work with families who give a lot of lip service to what they are. Yeah, we'll do that. We'll definitely do that. And then they don't. Those are the families who maybe have a false sense of everything's going to be fine. Kara, we can keep answering questions, but I can't see how many people are still here.
Oh, yeah. So there's quite a few people still here. So if you guys want to take just a few more minutes to answer a couple more questions.
Yeah.
But at this point, if anyone needs to sign off, you absolutely can, and you will receive your CE credit. But if you'd like to stick around for more Q&A, we'll be here to answer a few more.
Yeah, great. Nancy asked a good question on how often would we do risk assessments for a client presenting with some of the same concerns as Kyle? And Caitlin, I don't know if you want to speak to what triggers a risk assessment, like what triggers us to, are we doing them every day or is there something that, triggers us doing one again?
That's kind of like my senses went up with that one. We would obviously do that initial assessment with Kyle once all of this information was brought to us. And then, we wouldn't want to necessarily assess every single day, right? And be like, so how are you feeling now? How are you feeling now? That can also be very overwhelming and, agitating to teens. And so what we do is, as the need for assessments come up, it's really based on the level of risk. So we always want to follow up with that initial assessment and see if anything has changed, right? Has anything changed in regards to their plan, their intent, their means? And then from there, we kind of will establish this as a baseline. And anything that kind of deviates from that and increases in risk, we will then reassess again using actually our Columbia. So if Kyle, for example, has this, risk level, and then tomorrow is like, yeah, nothing's changed. I'm at the same place. But then the following, week is saying, I've been thinking about ways I'm going to do this. We would want to assess now again, because now there's an indication of plans. And maybe he says there's this plan, but I'm not wanting to act on it. I have no means, right? It's not going to happen. But then the next week he says, well, I've actually been thinking about, doing this thing. I've been thinking about how I might do it. I've been thinking about how I might access means. And I think I actually know how to do that. I know how to get the means, and I might act. So now there's another increase in risk because it went from potential plans with no means and no intent to now there could potentially be means and with some potential intent to act on it that he's expressing. We would want to reassess because, again, we're looking for those key things of, is there a plan? Is there accessible and realistic means? How lethal is it? And is he wanting to act on it? All of those things combined, when there's a shift, we want to reassess.
Yeah. I just think this is a great question. How do you bring up with a teen that their parents are aware of their passive thoughts and have shared them with the therapist? So maybe the teen didn't, I'm guessing like the client isn't bringing these up directly with us, but the parents are sharing, like, I think my kid might be having passive ideation. How do we speak to the client, even though the teen hasn't mentioned it in session? If the client is the teenager and not the parents, we don't have a mandate to confidentiality with the parents. And the parents, I'm assuming, are sharing this with us because they want us to work with it. They want us to address it with their teen. So I would be honest and open with the parents and say, I really appreciate you sharing this with me. I'm gonna bring this up. And I'm going to do it in a way that, doesn't throw you guys under the bus, but I am going to be bringing this up directly and addressing it with the client. And then I'm again going to just be, fairly transparent. Like, your parents shared this with me, and they shared it with me out of concern. And I'm so glad that they did. And, maybe, you could just tell me a little bit more about it, and just come from a non-judgmental standpoint. But, I don't know if you guys have heard this, but, I say all the time, with the therapists that I supervise, you can't work with anything that's not in the room. So you have to bring it into the room.
Mm-hmm.
And then similarly, how do we provide psychoeducation if we can't break confidentiality? My first thought is you don't. We provide psychoeducation around what we can talk about. If and if you're working with a teenager, especially in an individual context, right, and you're not doing family therapy. If it's a family therapy context, then I oftentimes just work with the client, the teenager, to bring it up themselves. We do a lot of coaching here around, like, I think this is really important to bring up in family therapy. Let's talk about what that might look like and what you might feel comfortable sharing and what you might not feel comfortable sharing and how I can offer support for you in that moment. And then there also sometimes is parent coaching, like, so-and-so is going to be sharing this with you. And, here's some examples of some validating responses. So sometimes it might look like that. And then other times, if we are maintaining confidentiality and the parents are unaware of a specific situation, then we're probably not providing direct psychoeducation. Sorry, there's so many good questions. I'm going to go with how do you navigate youth and families that are treatment resistant or that downplay the severity of these situations? That happens for sure. Caitlin, you want to take that one?
Yeah. I think, we do see this often, and part of it is also recognizing that if families, caregivers are downplaying certain situations, there could be a lot of other things like shame or denial attached to that, right? And so for us as clinicians coming from a very non-judgmental place, and Rachel, you mentioned this earlier, is this, approach that this is probably one of the hardest moments of these families' lives is having, your child in these positions, whether it is, endorsing suicidal ideation, having an attempt, having an inpatient hospitalization, being in treatment, even just disclosing to them that they've self-harmed, right? Those are huge moments for families. And so there's just these factors that can come into why they might feel treatment resistant or have a level of denial to that. And I think having that at the forefront is really important when navigating the conversations to them. Because for us, this is all we do most of the time. What we talk about, it is a normal conversation for us, whereas it might not feel like a normal or comfortable conversation for these families. And so, depending again on where they're at, meeting them there, but also for us, not downplaying it. The way we describe it to them is very much also direct and to the point, right? That we're not judgmental, we are using compassion. And we have to make sure that as the caregivers, they know what's going on or that they know what they need to do or what next steps we recommend. All we can do is make these recommendations and do our best to continue working with them and psychoeducating them on the potential downfalls of not coming to a place of acceptance or understanding of the severity. It's really comes down to constant communication and psychoeducation with them. But I do think it is very prevalent and can be challenging. And so always consulting on what the best approach might be in terms of navigating this specific parent is really important.
Yeah, we can't force clients or families to take certain things seriously, even, suicide. And so I think sometimes it's just acknowledgement about where they are in the wheel of change, right? If they're in, pre-contemplation or contemplation, then maybe our efforts are just to, move the dial a little bit, but that might be all we can do. Thank you.
Thank you.